Thank you so much, sir. Thank you for your kind invitation to this esteemed institution. It's really a pleasure to be back. So I'll be speaking on SBP and cirrhosis and rise of the MDR pathogens. Spontaneous bacterial peritonitis, as we all know, is infection of the ascitic fluid in patients with cirrhosis without any obvious intra-abdominal surgical source of infection. SBP can be diagnosed at admission, can be diagnosed 48 hours after admission. So once it is at admission, we have to take the history, whether the patient has had any contact with healthcare facility in the last 90 days. If it is no, it becomes community acquired SBP. And if it is there, then it is healthcare associated SBP. If the patient comes in at admission, does not have SBP, it's diagnosed after 48 hours, it's called nosocomial SBP. Ascitic culture, which is done and based on the PMN report, we all know what is bacteriocitis, SBP, and culture negative neutrocytic ascites. The only important thing here I want to say is that the pool prevalence of bacteriocitis is 23%, SBP is 39%, and culture negative neutrocytic ascites is 43%. Moving on, before 2007, there was no antibiotic prophylaxis given regularly to patients who had ascites. The prevalence of SBP was as high as 80%. After starting antibiotic prophylaxis, the post-2007 era, the prevalence has dropped to 12%, and 2% in the outpatient setting and 10% in the inpatient setting. Among those with the inpatient setting, 50% have SBP at admission and 50% develop it during the hospital stay. So we all know the pathophysiology of SBP. I will not go into that, but something which was interesting, which caught my eye, is lymphatic rupture. So with portal hypertension, there can be lymphatic rupture at the level of the liver, which can lead to, again, seeding of the peritoneum with the bacteria as well as fungi. We all know with worsening cirrhosis, there is worsening dysbiosis, there is gut barrier failure, there's immune dysfunction, more accumulation of fluid, and with the variceal bleed, further reduction in the gut perfusion, triggering SBP. There are certain genetic mutations which increase the risk of sepsis, but however, this is what worsens in patients with cirrhosis. So what are the risk factors for SBP? Firstly, advanced cirrhosis, low ascitic fluid protein, less than 1.5 milligram per deciliter, use of PPI. This is one thing which we can make a definite change in the way we prescribe PPI. Unfortunately, all patients admitted to all the wards are getting PPI for one reason or the other. And quite often they do not fulfill the indications. PPI usage should be limited in patients with liver disease unless really indicated. Acute variceal bleed increases the risk for SBP by about 1.5 times. Also, asymptomatic bacteriuria and impaired renal function increase the risk for SBP. So PPI, the meta-analysis shows it increases risk by 3.15 times, and this is something which we can make a change. When to suspect any patient admitted with liver disease who has worsening liver failure, worsening renal function, hepatic encephalopathy, patient having pain and diarrhea, we should consider a possibility of SBP. And if systemic signs of sepsis are there in the form of fever, leukocytosis, elevated C-reactive protein, clinical signs of peritonitis in the form of some tenderness, we should have a high index of suspicion, especially in the OPD setting, because 10% of the patients may be asymptomatic. This is very important to suspect SBP and treat at the earliest to reduce mortality. And we should not forget that there is a spectrum of secondary bacterial peritonitis, which we should suspect if the patient has a glucose of less than 50, LDH of more than 225, and a total protein of more than 1 in the ascitic fluid. So in such a situation, please look for intra-abdominal sepsis, and if the culture shows the polymicrobial condition, always look for intra-abdominal sepsis because that is eminently treatable. There has been a change in the spectrum of the bacteria that we are isolating in patients with SBP. Earlier on, before 1998, It was predominantly gram-negative organism, E. coli dominating the picture, and 45% was gram-positive organism with streptococcus on the top. However, in the last 2 decades, a decade later than this, increasing gram-positive organism, especially enterococcus, was noticed, and this is because of the norfloxacin prophylaxis, as well as increased interventions which these patients are subjected to now than what was, say, 30 years back. And now what we are seeing is increasing MDR. So there is a steady change in the spectrum, and that is why just a routine cefotaxime or ceftriaxone is not going to work. Between community-acquired SBP and nosocomial SBP, there's a significant difference. And community-acquired SBP is predominantly Enterobacteriaceae, and gram-positive organism is less than 9%, and the prevalence of MDR is only 2%. And the mortality is lower. So these are to be detected in the OPD setting and admitted and given treatment, and they will respond. The second are the nosocomial SBP. These are the bad ones. They are usually gram-positive cocci or MDR organism, and gram-positive cocci can go up to 55% in this, and the MDR organisms are usually gram-negative, and they are 22% here. This is associated with 4 times increased mortality. So this is the thing which we in our ward should pick up early and treat appropriately. So what is this MDR, XDR, and PDR? Among all organisms, they are either multi-drug, not multi-drug resistant, or multi-drug resistant. Within that, there is a small spectrum of extended drug resistant, and even a smaller spectrum within that of a pan-drug resistant. How do we make these definitions? The microbiologists have various classes of antibiotics, and these are their various classes, and these have evolved with time. So MDR is resistance to one agent in 3 antimicrobial groups. So we have so many antimicrobial groups, they have to report across all the antimicrobial group. And if you have resistance to one agent in minimum 3 antimicrobial group, it's called multi-drug resistant. XDR, that is extended drug resistance, is resistance to one agent in all but 2 or fewer antimicrobial groups. So it will be resistant across various groups, but 2 will be spared. And the pan-drug resistant is resistant to all agents in all the antimicrobial categories. So if you see MDR, here it is resistant to 3 groups, but it still retains sensitivity to others. So you have to ask your microbiologist to give you an extended spectrum here. For XDR, you can see that it is sensitive to 2 groups, but resistant to all the others. And you can have pan-drug resistant, which is across all the groups. Prevalence of MDR is on the rise, and India is the capital. The odds ratio of having MDR is highest if you're coming from India, 7.94. And for extended drug resistance, again, the odds ratio is very high for 13.57. India has become notorious for this particular problem. And with medical tourism coming up in the country, this is something we have to really guard against. Among the nosocomial SBP, if you see in Asia, 40% of the nosocomial infections are carbapenem resistance. That is because we don't have antibiotic stewardship. Our microbiology is not giving us the support that we need to make the initial diagnosis, and we are not sending cultures right at onset of the patient before they get antibiotics. And many patients come to the bigger centers after having received a shot of antibiotic in a private place. So it is very important that wherever you're practicing, ensure that you send a culture to a good lab before you start antibiotic. Mortality in SBP without treatment is 90%, with treatment is 20%. Diagnostic delay increases the risk of mortality by 3 times. So it is the golden hour in the emergency which matters. Tap patients at admission, give the first shot within 6 hours. And this is where we have to sensitize our residents and the emergency team to handle these patients. So the prognosis is very poor if there's renal dysfunction, nosocomial SBP, and gram-positive cocci. When to suspect MDR? Patient who has SBP in a healthcare setting or has a nosocomial setting, the hazard ratio is 4.43. That means 4 times increased risk if it is a healthcare-associated SBP or a nosocomial SBP. Patients who are on quinolone prophylaxis are at increased risk for MDR. And if they don't respond to the first line empirical antibiotic, keep MDR in your mind. Any delay is going to cause morbidity and mortality. So if you find that the first culture is showing high resistance to first line antibiotic, again think of MDR. The rates of cephalosporin resistance in nosocomial infections 49%, and in healthcare associated 21%, and community only 7%. That's why for community acquired SBP, cephalosporin is still the first choice. But however, for hospital acquired SBP, we have to be very careful of using just protein cephalosporin as a first line empirical therapy. MDR is associated with 50% mortality, so it is something which we have to detect early and treat properly. So there are now potential tools. We can do direct cultures, but with MALDI-TOF for picking up the exact organism and picking up the resistance pattern. But we lose a lot of reporting time here, about nearly half a day. And sometimes the cultures are not positive, the results are not reliable when there are mixed infections or fungal infections. So now there are tools to pick up using PCR-based technology, multi-pathogen probe-based technology, targeting bacteria and fungi with a sensitivity of 100% and the specificity of 91% in cirrhotics, and which shows good concordance with ascitic culture. However, it can be false positive because of lab contamination as well as PCR positivity. So drug resistance, how we are going to pick up may not be the similar DISC method which we saw as undergraduates. Things have changed. PCR probe-based methods are being used to pick up drug resistance. So how do you treat empirically patients with SBP? Community acquired SBP, low MDR prevalence, give ceftriaxone or cefatoxime, 4 grams and 2 grams a day, duration 5 days. Short course, good quality ceftriaxone, good quality cefatoxime for 5 days. You should stop your therapy at 5 days if the patient is responding. If you have high MDR prevalence, then piperacillin-tazobactam is a good combination, 4.5 grams 4 times a day, minimum for about 7 days. If it is healthcare or nosocomial SBP, this is a spectrum which we see a lot, and there is low MDR prevalence and the clip SOFA is less than 7, again, we can try piperacillin-tazobactam. If it is high MDR and the clip SOFA is high, then meropenem with vancomycin has better efficacy. Very important at 48 hours to assess response to the antibiotic you have given. TLC should reduce by more than 25% and the patient should be asymptomatic. If it is not happening, look for MDR or XDR, look for secondary bacterial peritonitis, look for spontaneous fungal peritonitis. If it is XDR, what are the antibiotics we have? Carbapenem resistant Enterobacteriaceae, tigecycline colistin combination. Pseudomonas aeruginosa resistant to carbapenem and quinolone, very common. Amica or colistin, combine it with carbapenem and ceftazidime avibactam. Ceftazidime avibactam is emerging as a very important drug in this spectrum of patients. Vancomycin resistant enterococci, we have linezolid. Daptomycin is coming up as a very important drug, and tigecycline. So ICMR has released recent guidelines for the New Delhi metallobetolactamases, and here prolonged infusion with ceftazidime avibactam and aztreonam over 3 hours is the first choice. And in fact, ceftazidime avibactam is emerging as the most important choice in these MDR organisms for KPC, that is Klebsiella pneumoniae, as well as class C beta lactamase and NDM and OXA 48. So ceftazidime avibactam with or without aztreonam. Similarly, at the IDSA guideline, again focusing on ceftazidime avibactam, we can't forget hand hygiene. This is very important because patient to patient inside the ICU, there's transmission. So to the administrators, I request to have sufficient nurses, and important thing is to emphasize hand hygiene for all these patients. And our washrooms are never so clean, and I think we are transmitting bacteria even in the washrooms of patients, and this is something which is very important. How to prevent? Use antibiotics, high dose, short time, 7 to 10 days, that is sufficient. De-escalate wherever the antibiogram is available, Antibiotic prophylaxis only in evidence-based indications like GI bleed, previous SBP, and risk factors for SBP, use contact precautions in all, and perform surveillance for MDR carriers among the patients as well as the staff. Treatment is important. Long-term mortality is high after first hospitalization with SBP. Consider transplantation after the first episode. Fungal SBP, just 2 slides on that. Prevalence is now increasing because of all these antibiotics. Candida albicans is the commonest one. It's associated with high mortality, increased chance of shock and admission to the ICU. And when to suspect fungal is prolonged antibiotics, percutaneous interventions and catheterization, advanced cirrhosis, renal insufficiency, increases chances of spontaneous fungal peritonitis. So you should have a high index of suspicion. We can use beta-D-glucan or pan-fungal PCR assays. Treatment is with echinocandins and high mortality without transplantation. So what is the role of primary and secondary prophylaxis? Norfloxacin and rifaximin. Rifaximin has an edge over norfloxacin, and we should stop primary prophylaxis if the ascites disappears and the patient has clinically significantly improved. And there is a gut-liver axis, and here we have non-selective beta blockers, which help in reducing bacterial translocation and thereby reducing SBP. So non-selective beta blockers, 57% reduction in SBP. So we should routinely use them in patients to prevent SBP also. For secondary prophylaxis, meta-analysis has shown that rifaximin is superior to placebo, and rifaximin seems to have an edge over norfloxacin. For secondary prophylaxis, this is a head-to-head trial between norfloxacin and rifaximin, showing that rifaximin has an edge over norfloxacin for secondary prophylaxis. For primary prophylaxis, both of them are equal. So to conclude, suspect SBP at admission always. Detect SBP by tapping doing an ascitic tap at admission. Treat SBP by starting antibiotic within the first 6 hours. Check for response at 48 hours. Watch out for MDR if there is no response at 48 hours. MDR is increasing, high mortality with MDR. India has become the capital of MDR and XDR. Suspect MDR in all those with nosocomial infection, healthcare-associated SBP, if there is no response to standard antibiotics, cultures are suggestive, or the patient has been on quinolone prophylaxis. Early diagnosis and appropriate antibiotics are key to survival. Prevent MDR. Primary prophylaxis only to the high-risk cohort. Non-selective beta blockers may have an important role. Hand hygiene, isolating the patient, and also think of fungal peritonitis in those who are not responding to the standard therapy. Cite, contribute, and be cited. These are 3 leading Indian journals, and we have so many of our faculty working for these journals. So submit your good original articles, which you would have sent outside anywhere else. Send it. Once we have better impact factors for our own journals, it will improve the impact of India at the global scenario. Thank you.